This is a question to you, sir,
Okay.
from one of the residents. What are the closest differentials for young onset Parkinson disease?
Uh, First and foremost, we always have to rule out the Wilson's disease, we all know, but it depends on the presentation. What is the presentation? Whether the whether the disease is symmetrical or asymmetrical. Then the other similar group of disorders we should not forget about the neurodegeneration with brain iron accumulation disorders, which also can present. Even the PLA2G6 variety, it can very well simulate like a YOPD. We have seen a couple of patients who just presented like tremor predominant Parkinson's disease, and these patients are exquisitely sensitive to levodopa. Even with half to one tablet of levodopa, they develop florid dyskinesias, violent dyskinesias, and even MRI brain may not show iron accumulation, and the other, then it depends what is the syndrome, what are the associated features. So the differential diagnosis can be varied. There can be innumerable causes of patients of young onset Parkinson's disease. We have to see what are the associated findings, whether the patient have associated spasticity, dystonia, cerebellar ataxia, then the differentials changes. But if a patient with Parkinsonism presents with young onset, then obviously first we like to rule out about the drugs, then infections. What is the temporal correlation with any features? So it depends on what. As such, differential diagnosis for
Yes,
young
sir.
onset Parkinson can be enormous.
Yes, sir. Thank you, sir. Sir, one more question, sir, from our residents. What is the role of the DBS in young onset Parkinson disease?
DBS is definite role in young onset Parkinson disease patients, and it is just as we know all know about the early STIM trial also. But in all these trials, the median age was around 50s to 60s. But definitely, young onset Parkinson's patients, 3 years, 4 years, 5 years down the line, we have exhausted all the resources, and if they have developed dyskinesias, motor fluctuations, DBS can be considered and should be considered rather than. And as compared to late onset Parkinson's disease patients, the surgery has much more greater benefit in these patients as compared to late onset patients.
Thank you, sir, for clarifying the query. Sir, as the time is permitting, one more question I shall ask, sir. Now that we are saying levodopa dyskinesia dependent on the disease duration, shall we start levodopa in a young guy as well instead of YOPD, as what we have seen in Ghana, Italy studies?
I think it depends on the disability of the patient. If the patient just mild disability, mild tremor, in my personal opinion, I would still consider dopamine agonists or anticholinergics in the first place. And if the disability is not controlled with dopamine agonists alone, or the patient develops side effects, then only I'll add levodopa. I know there may be mixed opinion from other people, but if there is disability is mild, I would probably still start the patient on dopamine agonists and later on add levodopa.
Yes.
Roopa, you want to answer?
Thank you, sir.
Yes, sir. Thank you very much for a very comprehensive talk. I just wanted to ask one question about the role of anticholinergics. Because there are two thoughts to that drug also. That do you feel that are you were concerned about, for example, cognitive or gait issues on long-term use in these patients? And on the other hand, do you feel that maybe younger patients may tolerate this drug better for some duration of time? And do you find it useful for patients who have maybe predominantly tremor and in a younger age group? Or are we concerned about cognition and freezing of gait issues in them also, as many studies have shown that current use as well as past exposure to anticholinergics can increase the risk for cognitive impairment and freezing of gait in future in Parkinson's disease?
Definitely anticholinergics have effects on cognition, but I think that is more common in the late onset patients in the elderly population, and young patients do tolerate it quite well. And if the patient has a tremor predominant disease, I would definitely use anticholinergics, and not in the bradykinesia or rigidity predominant disease. I would mainly use anticholinergics in a tremor predominant patient.
Also, for the benefit of the residents, could you also elaborate a little bit on the impulse control disorders that we see with dopamine agonists? So in your experience, do you feel that, do we see it at the same reported rates from other Western cohorts, for example, and are the behaviors the same, or are they?
I think we need to be much more vigilant, and we need to ask patients in every visit. Personally, I have not done any study on that, but I have a couple of patients on dopamine agonists who have reported especially hypersexuality, which the wives report or the spouse just report, and not the patient himself. I've seen a couple of patients who have who developed hypersexuality, and when I tapered the dopamine agonists, the symptoms did improve. So we have to be vigilant of this side effect, and we have to ask. I am not aware of any study from India, but definitely the prevalence is much more in the Western population as compared to the Indian population. Probably we don't ask this complaint much.
Sahil sir, Vishnu here.
Yes, Vishnu.
Yeah, so same thing, carry on with this. So you considering impulse control disorders, since how much we usually ask patients on every follow-up visit compared to that. So I would like to, because there is a time for a couple of minutes, I would share one example which I had.
Yeah.
So what happened was, when I was doing some interning with Kapil Sethi, I think I've told you before. So I was standing in his clinic. So he came and saw one patient, and then was interacting with the patient for some time and told, take out the dopa agonist in this patient. So the resident, the movement disorder fellow, was asking, she doesn't have any impulse control disorders. Why are you asking to take off the dopa agonist? Then he told me, then he came out of the room and he showed, I've been seeing this patient for a long time. It's not something new, but she's a very austere lady. Today she is wearing an Apple Watch with a gold stripe Apple Watch, something, and the new iPhone, the latest iPhone in that. Then he called out the husband outside and asked, how is the shopping going? The husband was putting his hands over his head. Don't ask me at that point of time. So unless it may look very innocuous unless we ask for it, and this one sometimes we may miss it. So for the resident perspective, it's you should.
Yes, I think it is very important to highlight that, and it is also important to understand that the behaviors may be a little different in our populations. Yeah. For example, pathological gambling is a classical ICD in PD, but many of our patients don't have the resources or the access to gambling. So that may take the form of, for example, buying excessive lottery tickets. So this was seen in a study from Sri Chitra, for example. So so it's very important when initiating drugs to these patients to discuss about gambling, about shopping, compulsive eating, and also maybe these behaviors like funding and hobbyism, and to keep a close watch and screen at each visit so that we can take appropriate action before it leads to significant financial or social consequences.
I also share a strange encounter. One of my patient's son, who was from a rural background from Punjab, and he was on pramipexole around 4.5 milligrams per day. And in one of the OPD visits, I was telling Ritu also that he told me that they had cows in their home. And he started telling me that he has started having sexual activity with the cows. And then I came to know that it is impulse control disorders, which is induced by pramipexole. And then I reduced the dose of pramipexole, and he improved.
So also, I think, would you like to comment, sir, about some data that in general seems to be coming in that says that compared to the earlier times when overall an incidence of severe dyskinesias, because with the levodopa sparing therapies, that is what we are trying to prevent, the onset of motor complications and dyskinesias. But over a period of years or decades, do you think it is true that that kind of severe dyskinesias, the rates have sort of gone down worldwide? And do we see that in India, or Is it just? I don't know if there are really good data about that, but this is a general impression that
When
data.
I reviewed the literature, the majority of these studies which had a 10 to 14 years outcome, they've all mentioned that the dyskinesias, the disabling dyskinesias were very uncommon. But I have a couple of patients on my follow-up, young patients who are severely dyskinetic, very, very dyskinetic. I've seen a couple of patients. Recently also I came across one patient who developed violent dyskinesias with small doses of levodopa. He developed psychiatric side effects with pramipexole. He doesn't want to increase the dose, and he has no money for deep brain stimulation. It's a very difficult situation in that scenario.
So Sahil sir and both to Sahil sir and Roopa. So one final question. So next time you see a 45 or a 42-year-old young onset Parkinson's, patient says that you start the treatment, and that's a typical scenario that we give. So we get whatever evidence we say to the patient for and for. So doctor sahab, aap decide karo jo chahe. So next time you will start levodopa or dopa agonist.
I answered to Snigdha also. Probably still I feel if the patient is mildly disabled, I probably will start dopamine agonist only. And if the symptoms are not getting controlled, I will then, rather than increasing dose of pramipexole, I may add a low dose levodopa along with that. As this risk of dyskinesias is much related to the dose. So if I am giving around 300 milligrams or 400 milligrams per day of levodopa, I think it can do.
Roopa, what do you think?
Yes, so I think again it is a very much individualized and decision that we have to take in conjunction with the patient. But as Sahil sir has discussed, patient's disability would be the major selling point here. So for whatever the age, if it is a very disabling disease, I would be more likely to initiate levodopa. But if not disabling, I still feel that there are advantages. For example, pramipexole you can use in an extended release preparation. The dosing, for some time patient could be managed with a single administration in a day. And also depending on the kind of profile of the patient, the work pattern, after discussing impulse control disorders, excessive daytime somnolence, especially if he is or she is driving a vehicle or operating machinery. So taking all these into consideration, we would make a decision. I would make a decision. So I use both and individualize that most times. But patient's disability is the most important. And even if I start levodopa, I attempt to keep it to the lowest doses possible, because as very lucidly explained by Dr. Sahil, it is the doses of levodopa that are more likely to result in motor fluctuations and dyskinesias. So we would limit that, and in that way, sometimes adding on pramipexole and keeping levodopa at a lower dose. That is also a strategy that we may follow.
I also have one question to both of you. What is the usual anticholinergic dose at which these patients respond and which they tend to tolerate?
You're talking about the tremor?
Yes, sir. Yes.
Tremor is like some patients do respond, but even if we add 6 to 8 milligrams or even go up to 10 milligrams, then there are a certain couple of patients, I can't tell you about the exact percentage, which do not respond to tremor. And then even if we add levodopa, then also they may not show that much benefit. So it's a variable response with these drugs.
Yes, and I am very conservative with anticholinergics because I am very concerned about the cognition and the freezing of gait. So if I very rarely do I initiate, and if I initiate, I try to keep it at the lowest possible doses. For example, trihexyphenidyl, usually maybe just 4 milligrams in a day, or definitely not more than 6 milligrams in a day is what I usually do.
Sir, one more question from the resident, sir. Sir, which you have already answered regarding role of DBS in young onset Parkinson disease. The one more question is, will it be like upfront DBS or a late DBS, upfront versus late DBS in YOPD?
Obviously, the indication of DBS will always come whenever we have exhausted the medicines and there are side effects with medicines, mainly motor fluctuation and dyskinesias. Only then we will consider the option of a DBS with the patient.
Thank you, sir.